Idaho Matters is brought to you in part by St. Luke's Pharmacy, now offering free home delivery. For daily medications or one-time prescriptions, home delivery is easy to set up. It's convenient and safe. St. Luke's Pharmacy, now delivering to your doorstep. Information on how to get started at stlukesonline.org.
Love Boise State Public Radio podcasts? They are free to enjoy, but not free to produce. If you can give, your support helps keep shows like Idaho Matters and Scandalize available to everyone. Donate now at boisestatepublicradio.org.
From the studios of Boise State Public Radio News, I'm Samantha Wright, filling in for Gemma Gaudet. It's Idaho Matters. What's the latest on Ebola and hantavirus? And after the death of NASCAR driver Kyle Busch, we wanted to take a closer look at the danger of sepsis. Plus, trying to stop the spread of lung cancer, breast cancer, colon cancer, or liver cancer. Well, a new study suggests that a new drug on the market may be doing just that. Too much sitting around could raise your risk of dementia, but a new study finds that some kinds of sitting may be better than other kinds of loafing. It's Wednesday, time for our Doctor Roundtable with Dr. David Pate, former CEO of St. Luke's Health System and the co-author of the book Preparing for the Next Global Outbreak. If you have a public health question, send us an email, idahomatters@boisestate.edu. Dr. Pate, welcome back as always. Thanks for being here.
Thank you, Samantha.
Okay, let's start with the Ebola outbreak, and let's get an update. Where are we with this outbreak?
Well, it's not good because if we have sufficient resources, we should be able to get this contained. We have done that repeatedly in the past, but right now, this is far from being contained. Cases are escalating rapidly, and that's probably just the ones that we're finding, not that we're getting ahead of this yet. So it is certainly not well controlled, and there's a significant danger that this is going to spread to more African countries.
So I've seen some stories about the scene at the site of the outbreaks. It's been chaotic, I would say at best. Some family members stormed a couple of the areas trying to find the bodies of their loved ones who had died. There was a fire in all the chaos. So I guess, what do officials there need to help them contain this outbreak?
Well, just about everything. First of all, there needs to be better security. It's difficult enough to treat people with this disease without there being attacks on your facility and healthcare workers being put in danger in that regard. So certainly there needs to be more security. I would certainly demand that the military government step up and provide that security to ensure the safety of workers. Unfortunately, when some of these facilities have been attacked, some patients with Ebola have fled from the hospital. So that is not good. That's going to lead to more spread. Second, they don't have all the equipment they need. The World Health Organization is responding, but you're talking about a combat zone, poor roads, very difficult to do this operationally, and but they need more personal protective equipment. They need more testing. They just need medical supplies, and so this is kind of a global crisis, which is why the World Health Organization declared a public health emergency of international concern. Because if they cannot get the resources they need and the security for these facilities, then this is going to continue to spread even further than it already has. And then the more African countries that this spreads to, then the greater chance now we end up with somebody in the United States with it.
So we've talked in the past on the Roundtable about how this isn't the first time Ebola has cropped up. The BBC says this is the 17th outbreak in the Democratic Republic of the Congo since 1976 when they first discovered Ebola. And I just want to check in. This strain that we're dealing with now isn't that common when we're talking about all these different outbreaks. This is more of an uncommon strain, right?
Yeah, you've got that exactly right. This will, by my count, be only the third outbreak of this particular strain, which, as you said, is much more rare. So those 17 outbreaks have generally been with different strains than this one. And what we are observing as of right now, but this is a very fluid situation, is that it seems to be transmitting much more rapidly and efficiently. But fortunately, we're seeing lower death rates than we do with some of the other strains. With this one so far, now that could change as we get more information. The death rate has been more on the order of 25 to 30%, as opposed to it can be even much higher with the more common strains.
That's really scary. Okay, so I want to try something new, Dr. Pate, since you wrote a whole book called Preparing for the Next Global Outbreak. And I want to ask you, on a scale of danger of 1 to 10, how worried should we be about this Ebola outbreak? Should we be worried here in Idaho? So I didn't get a soundbite, but scale of danger, bump, bump, bump. Where would you rate this one?
So it depends on how we think about what the danger is. If we're talking about a pandemic risk, then I put this down low, 1. If we're talking about a risk of it getting into the United States and having cases appear here, I would say if we cannot get this, and I say we, but the United States is not really helping all that much. If we do not get this under control, then if it continues to spread to more African states, then I think there is a very reasonable chance that someone will show up in one of our emergency rooms across the country with Ebola. This happened back in the 90s, and it happened in Dallas. The risk, though, will be to healthcare workers predominantly, not the general public. And the reason is that very unlike COVID and some of the other viruses that we've talked about, Ebola tends to transmit when it's later in the stage. So that's why we see healthcare workers. Unfortunately, we've had a number of deaths in Africa, but and that's what we saw in Dallas, is that it was two healthcare workers taking care of the patient that showed up, because in the United States, we're not used to dealing with this disease. And so we don't have a lot of high suspicion for this disease. I hope that hospitals across the country, if this does continue to spread in Africa, I hope it won't, but if it does, then we've got to go on more alert because we're just a plane ride away and a cruise ship ride away. And although the United States has implemented some travel restrictions, we have seen that, number one, because of all the chaos at CDC, they don't even have enough staff to do that. So they're calling and asking for volunteers. So that is not a good sign. And second, I'm not sure how many people want to volunteer to be exposed potentially to Ebola. So we'll see how this mess goes. But I don't think we should be overly worried. But what we should be worried about is that this is symptomatic, if you will, of a much larger problem. And that is that our preparedness in the United States is getting worse and worse. Our ability to respond to challenges of new viruses, dangerous viruses, is diminishing under this administration. There has been chaos wreaked at the CDC, at the FDA, and of all things, we have eliminated the White House pandemic coordinator position. So now that role was very important during COVID, and certainly some of these other potential threats could be even far worse than COVID. And yet we just don't have people in this. We're not taking preparedness seriously, and that is the biggest concern for America right now.
Okay, so let's look at another virus that's in the news. There's a new case of hantavirus in Spain. It's someone who was on that cruise ship where the outbreak occurred. What do we know about this new case?
So we have actually two new cases because another one just happened. Since you got the most recent update. So one of the person that you're speaking of is somebody that was on the cruise ship and was in quarantine in Spain. So that's the good news. That person was not mingling out in the public. They quarantined because of being on the ship, and that person just tested positive. I think it was Monday. There is another. We now just have another a crew member that just turned positive. So we're up to 13 cases. We've had 3 deaths. But this one is a very different story than the Ebola. This one, it looks like the response it's not been perfect, but it has been pretty darn good. And it's been good enough, it looks like. What I have been looking for is if this was going to be a problem, then I was looking for a surge of new cases last week and this week. And the reason is that although everybody focuses on the destination of this ship, there was a one stop on an island where they did let passengers off the cruise ship after the initial case, but before they realized they had this outbreak. So there were people who got off of that ship and then got on planes and went back to their countries. Those were the people I was worried about because they may not have known. They certainly weren't quarantined. But based on the timing, when I plotted it out, I would have expected that if that was going to end up being a problem, we should have seen a number of cases that were people not on the ship occurring last week and this week. And I'm knocking on wood because this week isn't over. Once we get to the very end of the week, I'll even feel better. But it looks like we're not seeing any of the cases that aren't related directly to the cruise ship. So that's really good news. My guess is, and I hope I don't have to correct myself next week if we do get more information at the end of this week, but my guess right now is it looks like this one is coming to a close. And I congratulate everybody for their response across the world.
Okay, so with that information on the new Dr. Pate scale of danger, where does this outbreak fall?
So this outbreak, I think, especially if, like I said, if we don't see new cases soon, then I think this one gets about a 0. Now, what we should remember is although we don't get this strain of hantavirus, thank God, we do get isolated cases of hantavirus, particularly in the western United States. But we don't get many. In the past 30 years, we've gotten just shy of 900 cases. So it's not a huge problem. The big problem for those of us in the western United States, and especially people in the Colorado, Nevada, Arizona, New Mexico area, is places that might be rodent infested due to inattention, maybe a shed, maybe a barn, maybe a garage, maybe some deserted property. Those are the kinds of places that do pose the risk when somebody then comes in and decides to clean up, starts vacuuming or sweeping, and then you get that virus aerosolized in the air and breathe it in. And that's when we tend to see cases in the United States, but of a different strain.
Gotcha. And so for the mouse, as opposed to the human to human spread strain, David sent us an email with this question: if a mouse has hantavirus in its feces, how long after the mouse defecates will the virus live or be capable of infecting someone?
David, that's a very perceptive question, very good question. And I have to say it depends. And the reason I say that is because this virus is very susceptible to environmental conditions. So, by that, what I mean is that ultraviolet light kills this virus very efficiently. And so, if it's an open area outdoors where there's direct sunlight, a garden, a yard, a farm, then the risk is not particularly high because the virus just can't survive. And we're talking matter of hours here if it's exposed to ultraviolet light. What is the concern is these areas like I talked about where they're covered structures, sheds, barns, stables, garages, deserted house, those kind of things where there might be a rodent infestation. In that case, we believe the virus can survive as long as just a hair over 2 weeks, actually. And of course, if it's infested, then they're probably still there. But that's why I use extra caution if you see droppings or anything. Just assume that there is infestation and just be careful about your efforts to clean that up. A great thing to do would be to just wet it down with wear a N95 mask and then wet it down with a disinfectant spray, because when it gets wet, then that dust and stuff isn't going to aerosolize so easily, and then you can clean the area.
Okay, Dr. Pate, NASCAR fans were shocked when driver Kyle Busch passed away suddenly of a condition that I think not many people know much about, sepsis. So what is it, and how does it affect the body?
So this was shocking because although most doctors that have hospital practices we're used to seeing sepsis, we're not used to seeing it in 41-year-olds that are reportedly healthy. So this was surprising. So sepsis is essentially an overwhelming infection. It's not localized anymore. It likely started very localized, but it means that it has spread through the body, and that can be through the bloodstream. Sometimes it is the infection itself is just spreading at a even though it hasn't spread into the blood yet, it's spreading so much and causing so much inflammation that your immune system is overreacting to it. But oftentimes, it's just an overwhelming infection. And what we see is that it can come on very quickly, and it typically makes people really quite ill very quickly. Things like their blood pressure dropping, heart rate racing. They oftentimes may get faintish or not able to stand up. They can get confused. There's a lot of different ways this can manifest. So we just have to be suspicious in anybody that we're treating or observing for an infection.
Okay, now Bush had pneumonia, and that may have led to the sepsis. So what other conditions can lead to sepsis? Because it's kind of a big range.
So the people that are particularly at risk, the highest risk, for sepsis are people that are immunocompromised, either because they have an underlying immune deficiency or because they're being treated, like, for example, with chemotherapy or steroids. So that's one group that's very susceptible. People that have lost their spleens can be at increased risk. And I wondered about this with Kyle Busch because a common way to lose your spleen is to be in an auto accident. And I couldn't see, I don't watch, I don't follow NASCAR as closely as I did when I was younger, but I'm not aware that he's been in a big traumatic crash that ended up him going to the hospital and having to have surgery. But if you lose your spleen, you're at increased risk. Also, people that have indwelling devices that are passing your skin barriers. So a catheter that is in your urinary tract to help you urinate, or a intravenous access with a line under your collarbone, in your neck, in your arm, those kind of things. And being on a breathing tube, a lot of times in patients that we are treating for COVID or something else where we need to put them on a ventilator, getting pneumonia is a very big risk. And then those people can easily become septic. But I would say, other than those kind of situations, the most common ones I see are either originating in the respiratory tract or originating in the urinary tract, where somebody has a urinary tract infection or infected kidney stone, those kinds of things.
So when I was reading on this, CNN said that sepsis contributes to more than 1/3 of hospital deaths in this country, and it can be very unpredictable. How scary is sepsis?
Well, it is scary because it can progress so quickly. And that's why we have to be, it doesn't happen. If you're a healthy person and you get a ear infection, a sore throat, a skin infection, you don't need to be consumed with worry that you're going to get sepsis. It can happen, but it has to get a whole lot worse. And it's just, the important thing is, don't ignore an infection that's getting worse. Get attention. But most of the time that we're going to see this is it either develops in somebody we've already put in the hospital for because concerns of their infection progressing, or because they are on chemo or immunocompromised. But the younger people and older people certainly are at high risk. Babies in their first 6 months of life, particularly vulnerable. That's why it's unusual in Kyle's case, because he was 41 and, as far as we know, was healthy. I have my suspicions in Kyle's case because, as you mentioned, it turned out he had pneumonia. And upon more information, now I don't have any personal information or access to his medical records. I'm just telling you based on what's in the public, so keep that in mind. But in the public domain, it was mentioned that he was sick a couple weeks ago with more like a sinus infection kind of thing, and that reportedly he got some kind of shot from a doctor. And I do have some concerns that that shot may have had something to do with it, because I'm wondering if he didn't get a shot of steroids, which, if he had an underlying infection going on, if you just do a one-time shot like that, you can suppress the immune system enough that this could get out of control. My guess is that for his case, this actually started with a virus. And then the virus was infecting his respiratory tract, including his sinuses. And then when that kind of irritates the linings, it makes it very susceptible to bacteria. And in cases his age, where I've seen somebody get deathly ill with pneumonia, a lot of times it's been right after influenza is the most notable, and particularly the risk of getting a staph infection in your lungs, which is very nasty and can be very serious.
Okay, so when I was reading on this, they had an acronym, TIME, TIME. What is this? And can it help us, try to figure out if we have sepsis?
Yeah. So TIME is an acronym that is used to just keep in mind warning signs that ought to be alerting us to the potential of sepsis. And the reason is the earlier we can intervene, the more likely the person is to survive their sepsis. So the T in TIME is for temperature, either a marked increase in temperature, or even in some cases of sepsis, we see people come in with really low temperatures. So either extreme of temperature is the T. I is either the person does have an obvious infection or they have symptoms of infection, such as fever, redness, warmth, those kinds of things that might indicate that there's an infection, or symptoms of a urinary tract infection, symptoms of a respiratory tract infection like coughing, stuff up, chest discomfort, shortness of breath. So it's anything that might be associated with infection. Then M is for their mental status. Are they confused? Are they sluggish? Are they not making sense? Are they slurring words? Are they, some indication that something is off there? And then the E is just that, especially when you've seen enough of these patients, doctors will get a sixth sense of just looking at somebody and saying something's not right. They appear more ill than they should be for just an isolated urinary tract infection or just an isolated pneumonia, those kind of things. So E is extremely ill. If there's some evidence of that, then we got to be really very concerned that this may have become sepsis.
Well, and it can be fast. It can be super, super fast. I have to confess, I, once upon a time, got sepsis. And it went from, totally normal. And in less than an hour, I had pretty much every symptom that you just described in time. How do you, especially in a clinical setting, this can be really, really scary. And I know hospitals and doctors, look for this to try, because you got to act right away.
Well, that's right. And so, we keep kind of drilling it into ourselves that we need to be alert about this, and especially in patients in the hospital that already are being treated for an infection, and particularly those that have these indwelling lines of one sort or another that I mentioned. And we have to have a very low level to trigger us to investigate if the person might be developing sepsis. So we look for some of those same things. Is their heart rate changed? Is it now racing? Has their blood pressure changed from their normal? Is their respiratory rate increased? Has their oxygen saturation deteriorated? And how is their mental status? And so any of these things, as the urine output dropped off, we look at quite a lot of things. And really, if anything is off the mark, then we immediately start a whole series of things that involve testing, as well as making sure that we're giving the person enough fluids and supporting their blood pressure and perfusion. And so, yes, you have to respond very quickly, because if you miss this and it goes on for a while, their chances of recovery are diminishing.
Wow. Okay, so say you have sepsis and you survive. You're one of the lucky ones. Hooray, you've beaten the odds. But then I was reading today that there's a post sepsis syndrome. This sounded scary. What is this?
So, post sepsis syndrome, in our estimation, can occur in perhaps as many as half of patients,
Oh,
and particularly those who got the sickest, and particularly if they required intensive care. Now, not you can still not have required intensive care and get post sepsis syndrome, but you're more likely to get it if you were particularly ill. So, those patients where we discover it and intervene quickly, much less likely to have this. But those that go on to full blown sepsis, about up to half of them can have it. And it is typically a collection of very broadly ranging symptoms. It can certainly, fatigue is very common. We see people that have persistent cognitive challenges. They may get home and say, I just can't concentrate like I used to, or I'm having problem, whereas I just didn't have any problem with my checkbook. Now, well, of course, now hardly anybody uses a checkbook, but but it's hard to balance my checkbook. Those kind of things it's hard for me to read. It's hard for me to keep my attention focused. Those kind of things. We see sleep disturbances not infrequently, and some people will notice that it's just doing simple things, they just get wiped out or get short of breath. So it can be broadly varying, but it is certainly well recognized that it can certainly cause this. And so that can be another problem for not recognizing this quickly and getting it treated.
We got an email from David with this question, Dr. Pate. Does Dr. Pate still recommend 2 COVID vaccinations per year for people 65 and older? He says, a nurse told me the current recommendation is 1 a year, and another nurse told him that 3 a year wouldn't hurt. So what do you think?
Yeah.
1, 2, or 3.
Well,
Those are your choices.
Yeah. Just don't be like the guy in the UK that took like 200 shots
Oh my gosh.
at the beginning of the pandemic. Yeah, it's so the nurse is correct that 3 probably won't hurt because we follow this man, and certainly a couple hundred didn't hurt him, but that's not what's recommended. So for most people, an annual vaccine with the update, and that typically comes out in the fall time. But for those that have underlying medical conditions, and especially for those of us over 65, yes, I still recommend, and I still get the 2 doses per year. One, so the update typically comes out at the end of August, beginning of September. So you would take one around that time when it comes out, and then mid-year take your second dose. The studies continue to show benefit, especially in our age group, of continuing to get those boosters because the immunity is not long lasting and the virus is still out there. And certainly we continue to see people get severely ill with COVID, particularly those that are in this older age group. So yes, 2, but no one's going to pay for you to get the third one. So.
Okay. All right, I've got another study on GLP-1 drugs. That's like Ozempic or Wegovy and some of the others. This one says that the drugs may slow cancer, including lung cancer, breast cancer, colorectal cancer, and liver cancer. What's going on? Every time I think we talk, we've got another GLP-1 study that says they're wonder drugs. What's going on with this one?
Well, it truly is amazing. I don't remember over the span of my career a new medication coming out, and then after it's out and in use, finding completely unrelated conditions to this degree.
Mm.
Occasionally, we'll find one or two other things that it will work, but this really has been quite surprising. What this study was an observational study, which means we are not going to be able to conclude cause and effect. In other words, the benefit that these patients got from those drugs, we can't say for sure from these studies that it was due to the drug, and I'll explain in a second. But what this does mean is that we did see enough benefit in some of these cases to warrant now designing a proper study that would allow us to answer the question, okay, is that GLP 1 drug directly responsible for the benefit? And since one of the large benefits of GLP 1 drugs is in treating people with obesity, especially those that have underlying diabetes. It made sense to look at people with cancers that we know are associated with obesity. So you mentioned a number of them that you are at increased risk if you are obese. And so what they did is they looked at these patients, and what they found is that for four of the types of cancer, and that was breast, colorectal, liver, and non small cell lung cancer, those four, the difference was statistically significant. So there's something there. Now, I cannot explain, well, why didn't it work on all obesity related cancers? Don't know. We're going to need to look at this much more. Now, why might these drugs work? Well, I think that, and we've talked about this over time, because, for example, months ago, we talked about studies showing that getting a shingles vaccine greatly decreased your risk of dementia. We found getting the flu vaccine did the same. And we're finding more and more that, and why we think obesity may put you at risk for some of these cancers is the inflammatory state of your body. And one of the things that we know these drugs do, although I don't think we've got the mechanism fully worked out, how much of it is due to the fact you're causing decrease in obesity versus some hormonal or mediator effects. But we do know that the level of inflammation decreases. And inflammatory environment is important to some cancers. So that may be one benefit. The questions that need more research is there a direct kind of anti-tumor effect? Or increasingly, we're looking at the ways cancers evade the immune system. So does the GLP do something to actually modify the immune response to make it more effective? So these are all studies that have to be explored. Including, are we sure that there is not only this association, but cause and effect?
And researchers did say it's too early to use these drugs as a cancer treatment, but people with a cancer diagnosis, I mean, when you hear the C word, you'll often try anything. So do you see this increasing the demand for these drugs, especially among people who have cancer or at risk for cancer?
Well, I think it will stimulate a lot of patients to go and ask their doctors about whether they should be on this.
Mm-hmm.
And I think that given that, this is early data, what this data allows us to do is to form a hypothesis and say, oh, okay, so our hypothesis would be that if you do have a malignancy that is associated with obesity, that using these GLP 1 agonists, perhaps it is interacting with those receptors on the cancer cells. And so now we'll design a study to look and see, do a control group and then look to see, okay, what exactly is happening in that group that receives the GLP-1 drug. Once we better understand this and once we can confirm the effect, then we can decide which patients are appropriate for these drugs. What I would say at the moment is if you have one of these cancers and there are other indications for the current indications for a GLP-1 drug, for example, you have underlying diabetes, you're obese, then yeah, that is a probably good reason because of the fact that we know it benefits that group for their diabetes and their obesity. Use it in that sense with the idea that perhaps if the studies bear it out, it will also help slow down the progression of their malignancy. But if somebody came into me to see me with one of these cancers, but didn't have diabetes or obesity, I wouldn't throw them on a GLP-1 drug just based on this study. Although there are many positive effects we found with these drugs, on the other hand, they're not harmless drugs, and they do need to be under a doctor's supervision, and we need to observe some people do get side effects, and they're expensive.
Okay, we've only got a couple minutes left, Dr. Pate, so I'm going to kind of squish this down. There's a new study that says if you're going to be a couch potato, there's a way to do it to maybe stave off cognitive decline. We've all been told you got to get up off the couch and move around to stay away from dementia. But apparently, if you are going to sit and be a loafer, there's a way to do it that may be better for you than others. What is mentally active sedentary behavior? That's hard to say.
So it is where, although you're sedentary, you're actively working out your mind. So reading a book where you have to be thoughtful, doing puzzles that are challenging your mind, either in a book or on an app or something. There are apps that you can get that do give you some mental exercises to do. So things where you're working out your mind. So I like how you framed it. Ideal situation is be physically active and mentally active. That's what's going to give you the most protection. If you're not physically active, if you are going to be a couch potato, and we are not recommending that,
No.
But if you are, at least keep your mind active, and that will help give you protection.
And I think this study was in the American Journal of Preventive Medicine in March. It did say what you said, reading, writing, problem solving, even office work worked. But TV is more of a passive, right? So avoid TV and maybe read or do something puzzly.
That's right. Watching TV, or if you're sitting there just listening to music or resting your eyes, those are that you're not working out your brain.
Working out your brain. I like that. Dr. Pate, thank you so much, as always. You are our guide through the medical health news morass. Thank you.
My pleasure.
We've been speaking with Dr. David Pate, former CEO of St. Luke's Health System and the co-author of the book, Preparing for the Next Global Outbreak. Don't forget, if you have a public health question for our Doctor Roundtable, just send us an email. It's idahomatters@boisestate.edu, and we'll try to get it on the air next week.
And that'll do it for this episode of Idaho Matters. Make sure you check out our podcast feed because you can find more episodes of topics that might be interesting to you. And for more local news and headlines, make sure you subscribe to the Connector podcast. Know someone who might enjoy our podcast? Be sure to share it with them today.
Every day on Up First, NPR's Golden Globe-nominated morning news podcast, we bring you 3 essential stories. At the heart of each story are questions. What really happened? What really mattered? What happens next? At NPR, we stand for your right to be curious and to follow the facts. Follow Up First wherever you get your podcasts and start your day knowing what matters and why.